Good afternoon and a very warm welcome to everyone joining us today, wherever you are in the world. It's great to see so many of you here for this EPA webinar, which is organized together between the EPA section on public mental health and EUFAMI for the International Day of Families. And we hope this will be a really engaging discussion on empowering caregivers, enhancing recovery. My name is Mariana Pinto da Costa. I'm the chair of the EPA section on public mental health, and I'm a reader at King's College London and an invited professor at the University of Porto. And I'll be sharing today's session with John Saunders. We're really pleased to be hosting this webinar. Caregiver support is such a central part of mental health care, but it's also an area where we have so much to learn in terms of implementation and everyday practice. So today we'll be looking at the evidence base, practical interventions, and the role of family associations in helping us design and deliver support that actually works in real-world settings. So we've got a really strong lineup of speakers, and I'm very much looking forward to the discussion. So without further delay, I'll hand over to John, who will introduce himself.
Thank you, Mariana, and welcome to all of you. It's absolutely delightful to see so many people on a Friday afternoon in joining for what we hope will be a very, very interesting session and discussion. As Mariana said, I'm John. I'm the Executive Director of EUFAMI, which is a European non-governmental organization that supports family organizations across Europe. And as such, we are obviously concerned and interested in supporting the role of families as carers in the arena of mental health, mental ill health. So it's great for us to be here. I'm looking forward to a really wise discussion. As Mariana said, we've got some really good speakers and some presenters, and we will have time for questions, and we're going to hold questions until the end. Depending on how we do in our time, we'll have 10, 15 minutes for questions. And I'll just say now, and I'll say it again later, if people are asking questions, make it a very brief question, which will allow the respondents to give a good reply. And also just say who you are and where you're from so that we know, although we can see some of the names, but not all of them. So thank you very much. We would ask you also to go on mute when the presentations are being made, just to keep the background noise low as possible. And we have, I believe, over 100 people registered to join here today, so the numbers are creeping up as we speak. So there will be people who join us over the next few minutes or so. So thank you. Mariana, back to you.
Thank you so much, John. So we're going to then start with an overview of the discussion and the session. So can I have some help in terms of sharing the slides that have been prepared, please?
That right away. So is it fine?
Yes, it's perfect.
Yep.
So again, thank you so much for joining us today. If you're in the webinar for empowering caregivers, enhancing and recovery, and that's where you want to be, you're in the right place. Next slide, please. And today we have 3 talks, and the first is a bit of a double act. We will be covering why caregiver support matters, the evidence-informed rationale on the role, burden and impact by Elisabetta Scanfarla. And then Romain will be discussing what to offer and give an overview of the different evidence-based interventions that exist. And they're both going to cover how to actually implement this caregiver support with practical strategies and tips that hopefully we'll have some time to discuss in the end as well with you. And then we will hear further about partnering with family associations and it will be a very good time to discuss this further and hear from Emmanuel Raymond on behalf of EUFAMI. So as you can see, there's these 3 sets of presentations, and then we will have time at the end for a Q&A session. Next slide, please. So without further delay, it is my great pleasure to introduce Elisabetta Scanferla, who is my colleague and member of the public mental health section that I share, and she has a PhD in psychology and is a senior lecturer and researcher at the Université Paris-Cité in Paris, in France. And then in this double act, she will be followed by Romain Ray, who is an associate professor and hospital practitioner, is the head of department of psychiatry at the University Service for Coordination, Rehabilitation and Evaluation, Lyon Expert Center in Psychiatry, East Division, Le Vinitier Hospital Center at Lyon in France. Sorry, like if I mispronounce the different languages, mixing French and English. So over to you, Elisabetta and Romain, and we very much look forward to hear your thoughts.
Oh, thank you very much, Mariana, for your kind introduction. So good morning, good afternoon to everybody. I'm very happy to introduce and give the first talk of this webinar. My topic here is trying to understand who is an informal caregiver. So let us first define what we mean by this term informal caregiver. An informal caregiver is any person who provides unpaid care to someone with a severe mental disorder. Most often they are family members, partners, or close friends. So now, what does the typical caregiver looks like? To address this question, we refer to the findings of the Caring for Carers survey, C4C, that was conducted in 2015 by EUFAMI, and you heard about EUFAMI before by John Sander. EUFAMI is a federation of family association and other mental health organizations representing 26 countries in Europe. And they run this survey, the C4C survey stands as the largest European survey of its kind, bringing together data from 22 countries and more than 1,000 caregivers. So some key figures from this survey: 76% of participants were female with an average age of 57. 42% had paid employment alongside their caregiving role, and participants reported providing an average of 21 hours of care per week, often the equivalent of a full-time job. And they also declare having been in a caregiving role for an average of 15 years. So next slide, please. So now, So now the question is, what is the spectrum of a caregiver task? Caregivers perform a vast multi-domain role spanning from practical tasks, emotional support, advocacy. So just a word on the 3 of them. Practical tasks, we mean medication management, attending appointments, administrative and financial tasks, housing and meals, safety and accident prevention. Second, emotional support. We mean monitoring mental states of their loved ones, support during crisis, listening and reassuring, managing challenging behaviors, a lot. Third part, advocacy, is mainly negotiating with services representing their loved ones, challenging stigma, maintaining social connection, planning for the future. So as you see, this is not a background support. This represents a comprehensive multi-domain contribution. Next slide, please. So If we consider all these aspects, we face a central paradox. And the paradox is, despite this crucial key role in service user recovery, caregivers are almost never assessed, seldom referred, and almost never included in care planning as full participants. Yet they urgently need support now. So let me now illustrate why caregiver support is a priority today, now. And I now mention some numbers. The first one is 35. Again, according to the EUFAMI survey I mentioned before, 35% of caregivers reported reaching a breaking point, a moment where they felt they simply could not go on in their current situation. The second number is 49. Nearly half of caregivers declare that the support provided by healthcare professional was not adequate, was inadequate. They were not receiving what they needed. Now moving to research data. At the same time, research across 10,000 of caregivers showed that nearly 1 in 3 experiences clinical significant burden. 1 in 3 lives with depression, which is a rate 3 to 4 times higher than in general population. Among women who make up the majority of caregivers, the depression prevalence rises to nearly 1 in 2, which is a significant number. So taken together, these figures describe a population with elevated, largely undetected and untreated mental health needs. This means that behind virtually every service user with severe mental illness, there is a caregiver who is likely in need of clinical attention. So caregivers are a population at risk, and let's explore their needs more deeply with Romain. Romain, over to you.
Yeah, thank you, Elisabetta. So this slide is a somewhat simplified representation, but it aims to map the different expectations and needs of caregivers. These needs and expectations, they are not always fully aligned, meaning that some expectations, they tend to be more immediately visible. For example, being listened to, dealing of the disorder, acquiring tools to over, which are equally important. They may remain in the background, even be fully recognized by caregivers themselves. For example, the need not to remain isolated or to protect their own well-being. Need to address this broad range of expectations and needs, and of course, no single intervention can meet all of them, and this is precisely why caregivers should have access to a range of complementary resources, enabling them to receive sustained and appropriate support. So now in this section, we'll get to the heart of the matter, and we will explore together different types of interventions available for caregivers. This is a very general slide, highlighting the wide diversity of interventions available for caregivers. Regarding the targeted objectives, you can see that they align closely with caregivers' expectations and needs that we have discussed just the slide before. It's important to note that no single intervention can address the full range of caregivers' needs on its own, and the key issue is rather to organize that caregivers can access in order to receive sustained support over time. Format, duration, and setting. Each modality has its own advantages and may be relevant for caregivers at different stages of their journey. For example, brief single family programs tend to be highly acceptable, whereas longer multifamily programs are particularly relevant for caregivers who already identify themselves in that role and are therefore often highly motivated to receive more in-depth information, tools, and reduce isolation through meeting other families. Delivery modes, whenever it is possible, facilitation by healthcare professionals and skills makes it possible to combine theoretical knowledge with experiential knowledge, which is the best. Slides, we will focus on caregiver psychoeducation, and caregiver psychoeducation is one of the case support available for caregivers. It offers several important advantages. First, this intervention benefits from a strong evidence-based. Indeed, it was initially developed for caregivers of individuals living with schizophrenia, and it has therefore been widely studied over time. And as a result, we now have very robust evidence showing that it is highly effective in improving caregiver outcomes and indirectly patient outcomes as well. In fact, caregiver psychoeducation is one of the effective interventions for reducing the risk of relapse or rehospitalization. Secondly, it is an intervention that can be readily generalized because psychoeducation for caregivers relies on core competencies shared by all healthcare professionals because it addresses needs that are common to all caregivers. And by comparison, family therapies, although very effective too, they tend to reach only a small specifically trained to deliver them, and because they are generally involved caregivers who are already highly motivated to engage in such interventions. Lastly, I wanted to insist on the term psychoeducation because it can sometimes be rather, it's a collaborative intervention in which facilitators tailor the information and support provided to the specific. The aim is to help caregivers regain, strengthen their coping capacities, and protect their own well-being. And this slide outlines the most important content psychoeducation should offer to families, to caregivers, in order to address their expectation and needs. And as you can see, this can be organized into several broad domains. First one, acquiring knowledge about the disorder and the organization of care. Second one, developing practical skills to better support their relative, with a specific critical focus on how to deal in situation of acute relapse. Thirdly, becoming aware of other resources available to caregivers in order to protect their own well-being. And lastly, meeting other caregivers in order to build a supportive network. One very important observation we have made in France over recent years is that caregivers are often unaware of the resources specifically available to support them. And as a result, they need gateway interventions that can help them initiate their support pathway, accelerate access to other resources. Such gateways, they should be multiple. Some should be provided through family association, while others should be embedded within healthcare services. And here is the caregiver pathway entry point that has been developed in France and now being progressively scaled up across the country. And this gateway program is called the BREF program. In France, BREF serves as an effective gateway program. The BREF program must be highly acceptable, since the goal is to offer it very early in the caregiving journey, sometimes to individuals who do not yet identify themselves as caregivers. This is why this intervention is brief, 3 one-hour sessions, delivered in a single family format and without the presence of a supported relative. Also, to function effectively as a gateway program, highly accessible. And this is the case as it is available upon direct request from caregivers. It does not require the consent or involvement of the relative they support. It is also a trans-diagnostic program, meaning that caregivers can participate regardless of their relatives' situations where no formal diagnosis has yet been established. And last but not least, the program is specifically designed to accelerate caregivers' access to support resources. The way it achieves this is through the final session, which is co-facilitated with a volunteer from the family association EUFAMI. This helps caregivers to engage with the resources offered by family associations. This helps connect them with peer support and pay greater attention to their own well-being. Your turn, Elisabetta.
Thank you, Romain. So given the time available today, it is, of course, impossible to cover the full range of existing caregiver psychoeducation and support intervention. We will therefore focus on a few selected evidence-based intervention. The first one is structured manualized single-family intervention, typically delivered over 6-9 months, often conducted at home with 2 healthcare professionals. It includes 3 core components: psychoeducation, illness medication, and relapse prevention tailored to the family needs. And now I'm talking about sorry, it's not in the right order on the slide. I'm talking about the behavioral family therapy, BFT. That's the intervention the program I'm presenting. This program has demonstrated efficacy in reducing relapse rates and improving social functioning and quality of life. This is a single family program, is a little bit longer than the one, the first initial brief program that Romain presented. And I'm presenting the program in at the beginning of the slide. Beyond the single family approaches, there is another one called the Macfarlane's multifamily model, first square. It's a structured multifamily intervention combining psychoeducation and problem solving. Its key benefits includes normalization. What's normalization? Is when caregivers realize that they are not alone. I'm not alone. This is a key understanding for each caregiver. Other benefits are social network expansion and social learning. This is about, I would say, face-to-face interventions. But beyond, alongside face-to-face programs, a growing range of digital intervention is expanding access to caregiver support. What I mean that there are face-to-face programs are key, but sometimes they're not available. So just to say that now digital intervention are a kind of answer. I would like to mention a couple of them, 3 of them. The first one is React. React is a free online psychoeducation toolkit with peer support for caregivers, and especially caregivers of people with psychosis or bipolar disorders. Second platform is MySpot. My Spot is a manualized intervention for young adults with a parent experiencing mental health disorders or substance use disorder. Donc, the specificity here is the fact that this is targeted to young adults. And the third one is Partners Connect. Partners Connect is a web-based program integrating motivational interviewing, CBT strategy, and self-care skills. Now I will hand over to Emmanuel, who will present an additional group intervention for caregivers that is entirely peer-led. Emmanuel?
Thank you very much, Elisabetta. Before
Yes.
Emmanuel speaks, I'd just like to formally welcome her. Emmanuel is a president of EUFAMI, a very significant and important family organization in France. And she's also importantly a family member. And also, I'm delighted to say she is a board member of EUFAMI, has been for a number of years and has made a valuable contribution to the work of EUFAMI over many years. So without further ado, Emmanuel, I'll hand over to you.
Yes, thank you. Thank you very much, John. And I'm very happy to be part of this webinar because as we have noticed, it's about family caregivers and I am a family caregiver. So as a patient, we would say nothing about us without us. So here am I. And thank you for allowing me to share a few ideas and a few experience about what it is and to be a family caregiver and what we do at EUFAMI and EUFAMI to try and get used to this particular situation none of us have chosen so far. So my name is Emmanuel, as it has been said, and I'm from France. I had a career as a publisher and journalist specialized in children's books and education, and I'm also, as I have just said, a family caregiver. As such, I became a volunteer for the French National Family Organization, EUFAMI, and I have been elected as the chair, the president in 2024. EUFAMI has over 16,000 members in France, as is in contact with 58,000 families on a peer-to-peer basis every year through active listening, information, and training of about 350 support centers throughout France and overseas. So it's a major national association, very active and involved, and it's been the case for over 6 years now. I have also been a board member, as John has pointed out, for EUFAMI for 6 years. This is the European Federation of Obsession of Families of People. I'm very happy to be part of the board. So let me first introduce you to the origins and dissemination of the program designed in Europe by EUFAMI 25 years ago. So the Perfect program was inspired first by a book written by Ken Alexander, an Australian doctor and father of a child with schizophrenia. His book, called Understanding and Coping with Schizophrenia, was published in 1991. When the author lists 14 principles he presented at a EUFAMI seminar in 1998 in Ireland, and my 3 favorite principles are, for me, get informed on mental health diseases, escape the inner pressure by building on your best side, and avoid self-sacrificing. Keep on socializing, doing sport, reading. EUFAMI Members Association decided to build up a training program to improve the quality of life of their member families, inspired by these 14 principles. It was not focused on schizophrenia, but on any kind of serious mental illness, because the key for the recovery is not the disease, it's the way each family caregiver can cope in the long run with mental illness in our families. So it has been a very big and huge European collective work since 1998. 16 family associations, all members of EUFAMI from 11 countries, wrote the Prospect Education Program between 2001 and 2004. They didn't do it all by themselves, of course. They were helped by an association of psychiatrists, the Royal College of Psychiatrists in the UK, and a team from the Sahlgrenska University Hospital in Göteborg in Sweden. A total of 40 people were involved, primarily members of the EUFAMI board. Funding was provided by the European Commission, private funding, and the own funding of the funds of the partner association. So EUFAMI decided to call the program Prospect. Why? In English, prospect refers to the possibility that something good will happen in the future. So the training program refers to a happy possibility. Indeed, our family history, even though it is affected by a serious mental illness, can change in a positive way. The full name of the program, Prospect Training Program, combines hope with practice, two fundamental principles of peer support. So if Prospect has become a brand name with its own logo and it's easy to pronounce in all European languages because, of course, Prospect Youth Program has been originally written in English, but it is being translated into all languages possible every time a country decides to implement the program at home. So the program is structured in models. There are 10 models that each of the models lasts 2 hours and follows a specific pattern. The way you can implement it depends on every country. Sometimes it is once a week for 2 hours over 10 weeks. Sometimes it is 3 days in a seminar format or 2 consecutive weekends in a 2 days plus 1 day format, or it's combined with evening full days. Each organization does it the way which suits best and the way which suits best with the funding the organization tries to have and looks for. Even if the program is provided by volunteers, there's of course additional costs. So these 10 models are oriented towards change and the desire for wellness. The families who sign up for Prospect are all motivated by the desire to change their posture, by doing things differently in order to cope with their loved ones' mental health issues in a long-term perspective without being overwhelmed. You don't start doing Prospect. You do Prospect because you have already been familiar. You have joined a family association. You have realized that it is a real burden for you. You feel too much stress and you have a real desire to change. This is why you come to Prospect. You have to be highly motivated. So people get together. So it's not one family. It is between 8 and 12 people. Some countries decided to focus on only siblings or only parents. It depends. In France, we don't mind. We think it's better to try and have a diversity of points of view as parents, in-laws, step-parents, co-parents, or anything, brother-in-law, sister-in-law. We have a whole range of family relative, which we think is better. So the first model, participants try to get to know together as a group, and that very soon realize that they're all here in the same situation of caring for a loved one affected by a serious mental illness, and the facilitators as well. This is a peer-to-peer program. There's no healthcare professionals involved. Diagnosis is not considered as being important. Psychiatric symptoms are not very important. What is important is the people themselves. So the second model is what we have learned about people's mental health, but not from professional, but from a truly experiential knowledge, what we know about our loved one because we live with him, because we care for him. And then all the following models are no longer focused on our loved ones and their disorders. And at the beginning, it is very hard, believe me, but it's focused on on ourselves, on the family caregivers. We focus on what ails us and what makes us suffer in our loved one's illness, the pressure or stress or pain or grief. This is from model 3 to model 5. And it is very important to come out of the denial that we have sometimes. So we do grieve the way that the situation has dramatically changed for our loved ones because of the disease. And we have to learn and accept it. Then from model 6 to model 10, we focus on our abilities, on what we have within us and beside us to care for our loved ones in an adjusted way over time, and to care about ourselves by setting objectives to changes in our attitude. So we go from our loved one to ourselves. EUFAMI, and now I would like to speak about the dissemination of this program. EUFAMI provides its 27-member association with the Prospect program, but 5 countries are most active: Finland, France, Slovenia, Spain, and Sweden. 5 additional countries started a few years ago: Belgium, Croatia, the Czech Republic, Greece, Hungary. Altogether 10 countries. The first country is France with the family association EUFAMI, because France organizes an average of 50 sessions of 10 people per year. Last year, it organized 50 sessions of 500 informal caregivers. So over 8,500 people have been trained since 18 years. In Europe, for 1 year, in 2023, this is my last figure, over 1,000 people have been trained. So why are so many people who come to EUFAMI propose to join and get a Prospect program? Because EUFAMI decided to turn Prospect into its flagship program for families for 2 reasons. Why? A practical factor. We don't have to wait for psychiatrist units to implement psychoeducational programs for families. There are so few. So we had to start quickly, just as EUFAMI decided to do it at the beginning of the century. And also for a strategic factor, because Prospect is a peer-to-peer approach without any mental health professional. It values the expertise by experience. It is, as such, very empowering for families, and it speeds up our own recovery process. The budget now. The program is, as I said, delivered by trained family members who are all volunteers, but there are costs linked to the implementation of the program: meeting rooms, housing, meals, coffee break, documentation. Some organizations who don't manage to get public funding decide, for instance, to do it twice, over 10 weeks, 2 hours a week, so you don't have to house people and to organize big meals. So in France, we are lucky to be supported by a national public agency. So we do it in a seminar format or over 2 weekends, because we think it's highly profitable for all the participants. So it's roughly 4,000 euros per session, but everything is supported and by the public national agency. And now the evaluation. We all would love to know how much people love a Prospect program and how they react to it. The rating is always very high. For instance, in France, everything, because we have public funding, we are being asked by the national agency to provide indicators. So we have many indicators, but there are evaluation of the participants, self-questionnaires. And participants always give a very high evaluation of 87%, the rating of satisfaction. And in other countries, the evaluation is not as systematic as it is in France, but you also have verbatim. So, and first I chose to quote what Annika Fort, who's in Finland and is a married person with 2 children. And she has 2 people in her family affected by a severe mental illness, her mother and 1 sister. And this is what she said about Prospect. She said, before Prospect, I had no life. And now I demand to have my own life. Before, I was always on the phone, answering to my mother, my sister. After Prospect, I set limits. Before, I would drop everything to help my mother and my sister. Now I have found a balance in my life. Before, I tried to be the solution of their problems. And after I realized that I have my own limits, I can't do everything for them. So I'm happier to the point that I was able to have another child and have 2 children in my family, which I didn't dare to it because I felt I was so overwhelmed by my sister and my mother. So the revised program has been also reviewed from the Education Committee of the EPA in 2023 and got a very positive feedback on the content, structure, and design of the facilitator manual. We were very proud to say that I think, John, we had 5 out of 5 everywhere. And very proud board, EUFAMI board members were so pleased with this very good results, but we worked very hard on the revised version of the program. But now we do know that we need to conduct a scientific evaluations to measure the impact of the program on the participants, and we are working very hard on it. So thank you for your attention. Any question or comment is, of course, welcome.
Thank you very much, Emmanuel. My apologies for reasons we just can't understand. The presentation was stuck on the first slide during Emmanuel's presentation. I don't know what happened. Apologies. But I think we agree that Emmanuel was able to give a very, very good overview and explanation of Prospect. We'll try and correct that, obviously. But now we need to move on to the next session. And it's back to remand for the session which is on your screen now, how to implement caregiver support, practical strategies and tips. Thank you.
Thank you, John, and thank you very much, Emmanuel, for this very insightful talk about Prospect. And now in the section, we will take a practical look at the steps involved in implementing a caregiver support program within a healthcare setting. And before moving on, we wanted to introduce the care model, which is a model developed by Australian and Indian teams. This model helps categorize the different types of support interventions available for caregivers. At the base of the pyramid are located brief gateway interventions that should be accessible to all caregivers. And as you move up through the levels of the pyramid, interventions become progressively more intensive. And the top 2 levels can generally be considered only for caregivers facing particularly complex or high burden situations. So why do we introduce this model? For 2 main reasons. First, when you begin developing a caregiver support offer within your healthcare institution, this model will help you map what already exists, and by contrast, it will help you identify the gaps in your current provision. Secondly, this model will help you with prioritization. Indeed, the first priority should be to make the base of the accessible, because those interventions are relevant to all caregivers and typically rely on brief programs that are easier to implement, such as the BREF program I talked about earlier. And briefly, level 1 corresponds to gateway interventions designed to assess caregivers' needs, provide initial support and guidance, and connect caregivers with the other available resources that are the higher levels of the pyramid. Caregivers to continue accessing interventions that address their ongoing needs and expectations. This level also creates opportunities to meet other caregivers, build a support network, reduce social isolation. This specific level is very interesting because it's not always provided by the hospitals or the healthcare institutions. It can be also provided by the family organizations. And for example, in France, practically all the interventions that are step 2 are provided by the family organization, such as the EUFAMI that we talked about earlier. Level 3 consists of longer psychoeducational programs with more comprehensive content. Those programs are aimed at strengthening caregivers' knowledge, practical skills to better support their relative. They are also aimed at protecting caregivers' own well-being. And as I told before, level 4 includes more intensive interventions for caregivers who continue to experience unmet needs despite having already benefited from. So here is a proposed process for implementing and structuring a caregiver support pathway within a care institution. And as you can see, this involves several successive steps. And in the next slides, I will focus specifically on the first 3 steps. Indeed, those steps are designed to enable the early and systematic support for caregivers and to initiate their support pathway. Before the first step, there is actually a 0 step, which is identifying which caregiver support intervention already exists within your institution or across your local health territory. And this is why we talked about the family care model. And this mapping step is very critical because it will guide you to determine what is missing and what still needs to be implemented. The first step is to implement a gateway program within your institution, corresponding to the first level of the pyramid of family care model. This is the gateway program in the healthcare institution that you chose in France. And implementing a gateway program within an institution, this requires training healthcare professionals so that they can become program facilitators, while at the same time training volunteers from family organizations, because those programs are better if they are delivered by health professionals together. Means that you need to build partnership with family organizations, since those are best when co-facilitated. However, training mental health professionals alone is not sufficient. It is equally important and maybe critical to train managers. I mean, physicians, chief nurse, and maybe institutional leaders such as directors of the hospitals. Although those people, they will not themselves become program facilitators, they are essential for creating the conditions that are necessary for a successful implementations. And those conditions, they include dedicated time and human resources to support program delivery within the institution. Another important point when you plan to implement caregiver support intervention is to integrate into those interventions validated assessment tools. These tools are important for 2 main goals. First one, they enable facilitators to identify caregivers experiencing the highest levels of burden or distress. But they are also essential for evaluating the intervention itself and assessing its effectiveness over time. And managers in hospitals, they are very, very interested in dimension. Once you have implemented gateway program, the next step is to promote the early and systematic referral of caregivers. So this obviously requires effective communications through flyers, through posters. But one other particularly powerful strategy is to integrate caregiver support awareness modules into continuing professional educations. Those continuing professional education modules teach staff as part of onboarding, while also remaining available to staff already recruited, already in posts. short awareness sessions can also be delivered directly within clinical services and can be very highly effective. And altogether, those approaches, they help to create of caregivers and their support needs. More precisely, the goal of awareness raising is not to turn every healthcare professional into an expert in caregiver support. That's not possible. Rather, the aim is to help them develop simple reflexes that promote a proactive outreach approach toward caregivers. And for example, at the moment in France with EUFAMI, we aim to foster what we call the caregiver reflex among all healthcare professionals. This consists of 3 very simple questions that should systematically be asked by healthcare professionals to any relative of a person living with a mental health condition. And those questions are and have you heard of breath, which is our gateway interventions in healthcare settings. Obviously, there are more advanced steps, as I told earlier, but I will not discuss them because they are more complicated, but I will be very happy to discuss them if there are questions at the end of the webinar.
Thank you very much. Now we're moving on to the next session, which, as you see on the screen, is partnering with family associations from Emmanuel and Elisabetta. So over to both of you and in any order that you wish.
Yeah, if you would like, I can start just with a couple of general slides, and then Emmanuel, you feel free to comment and any information, missing information. The question here is the question of how to partner with the family association. And the starting point is to recognize that family associations represent a vast, largely untapped resources of caregiver support, as the presentation of Emmanuel about prospect just brilliantly underlined before. So EUFAMI at European level, but also national associations such as EUFAMI in France, Rethink Mental Illness in UK, Similes in Belgium, BBAPK in Germany. All these associations often deliver training, peer support, helplines, and policy advocacy at scale across Europe. The clinical reality here is, however, that most services engage with these associations in a superficial manner, at best reducing them to a leaflet, rather than a structured referral policy and a partnership pathway. So the question here is, how can we build stronger relationships with local family associations? Then effective strategy exists for developing meaningful partnership with family associations, and these strategies vary in their level of commitment and resources required. So moving to the next slide, I will just list, remember a couple of, 5 concrete strategy. First strategy, the starting point is to invite a family association representative to a team meeting in your institution, in your organization. No budget required, no formal partnership agreement needed, simply an open dialogue, introducing the team, learning what the association does, exploring how collaboration might work. First step. Second strategy, share information about local association with all caregivers at first clinical contact. This is a simple step with no cost. Third, strategy number 3, ask a caregiver advisory group to provide feedback on the psychoeducation intervention provided by your institution, a feedback on information material targeted to caregivers used in your organization, is another way to involve and engage and develop the collaboration. Strategy number 4, support caregivers group by offering meeting space, if possible, of course, or clinical supervision. Many family associations run peer support groups, as we see before, but often they lack material necessary resources. Strategy number 5, where possible, advocate for including caregiver representatives in the quality improvement committees of your organization to strengthen the partnership with the family associations. These are just some ideas, but I think that, and you see there's a sense of progression there. Yes, it's basically what before presenting this slide, Emmanuel, would you like to add any comment information about how to better partner and develop collaborations with the family association?
Yes, thank you, Elisabetta. Yes, I may add a few words. I want to stress the fact that we are a network, and we have to think ourselves as a hospital and family association as a network, and we are partners, and each one has his own identity. We don't try and make up for the other one. This is very important. What I want to stress as well is that these associations started because of the stigma. Because it is so hard to speak about a loved one, a family member who suffers from a severe mental illness within your own family or with friends or at work. So people either minimize the situation or make you feel guilty. You must have done something wrong. So this association have started somehow undercover to try and build up a safe place for all families. And this is something that should not be forgotten. So it is a highly sensitive stuff, I would say. It is highly connected with stigma, and stigma still exists. And stigma, the society still says that it's nothing. If your loved one, you say he has a psychiatric condition, or looks at you in a very suspicious way. What did you do for this to happen? And I would like to say that healthcare professionals can still have a lot of stigma. I heard not long ago, a few months ago, somebody telling that EUFAMI representative a healthcare professionals mentioning to somebody that EUFAMI representatives are all mad, just like their loved ones. So this is very harsh, very difficult to listen to, but we know it's still here. So I really thank you for you to participate into this webinar, because I'm sure you want to change something. And there is a lot to change on the side of healthcare professionals. That we are not a toxic family. We are not responsible of the disease. Even if sometimes the family situation is so hard that the families caregivers can't be caregivers. This is true, but this is something we do need to have advocacy work done for us, the families, on the side of hospitals. I would like also to mention that all these family associations started by building up these small support groups. There's a safe place. You can talk openly. Nobody will judge you. Everybody will start listening to you. And more, they started building up programs either facilitated by psychologists, mental health professionals, and peer, or only by peer. It depends. So this is how these family associations started. But the starting point is always stigma. And it's not a long time ago. Stigma is still there every day in our societies nowadays.
Thank you, Emmanuel.
Thank you. I would like to suggest we are coming slowly to the end of this webinar, and I would like to sum up some key messages from today's webinar. The first message is every consultation involving a service user is also an opportunity to assess their caregiver. And that requires the intentional decision to turn attention to caregivers, even briefly. Message number 2, implementation starts with systematic caregiver assessment. And simple tools are available. As Romain said, some scales, the Zarid burden interview, the CEESD for assessing depression. These tools are very simple. They just take 5 to 10 minutes to be completed by the caregiver. So think about that. Message number 3, intervention intensity. And Romain stressed this point. He was right doing it. Intervention intensity should be tailored to each caregiver's needs. And that should follow a stepped care approach. In other words, the right level of support at the right time to the right person. Message number 4, before concluding, that there are no programs here, we don't have resources, etc., etc. It's crucial to map locally available resources. Family association, peer groups, digital tools, community services, these exist in most areas, but clinicians are often unaware of them. So map it. Message number 5, family associations are a key resources and an overlooked partner. We largely developed on this topic. So here you have 5 key messages, 5 concrete actions to empower caregivers. Just it is a kind of a wrap-up message from this webinar. And what we thought with Romain is to also add another concrete note. And to close, we would like to invite you to reflect on what we have explored together during this webinar, and to translate that reflection into action within your own clinical context in support of your patient, of your clients' caregivers. You can easily do that by asking yourself the following questions. First one, which intervention would best suit your caregiver's needs? Think specifically. Second, who in your team, in your organization, in your institution would be responsible for assessing and coordinating caregiver support? This is a key point. How? What are the 3 most concrete steps you could take within the next 3 months in this area, and what can realistically be done? There are also barriers. So think about what is your biggest anticipated obstacles. Is it time, resources, cultural resistance within your team, the absence of local programs? And just said that this doesn't exist, then programs and resources are everywhere, and now you might begin to address it. So many action leads to consider. Then over to you. Thank you.
Thank you very much, Elisabetta. That's a very nice ending to the formal presentations. And on behalf of everyone, to thank you all, not just for your presentations, but for your excellent timekeeping. We now have about 15 minutes to question and answers. Before I do that, I just say to people, please add a question, short question to the chat. And before I deal with the first questions, I just want to note in the chat and welcome Kathy from Canada and Anne from the Philippines, who have both given some account of their particular situation. The Canadians have started a new organization. Congratulations and well done. And Anne in the Philippines notes that there is no national equivalent organization to EUFAMI. So hopefully there might be some movement there in the future, and we wish you the best of luck in trying to do that. So we have got some questions that came into us during the session. So I know you've answered some of these questions already, but I should put them back to you and ask any of you to respond to the question, and then we'll go back to the chat and see if there's further questions coming in. The first question is, just reading from the list, excuse me. What strategies are most effective, in your opinion, in empowering caregivers while also protecting their own mental health during the recovery process? So it's about the caregiver's mental health as well as the well-being of their loved one. So, Emmanuel, maybe I'll throw that to you as a family member. As a starting
Yes.
point. Is that okay?
Could you please type the questions or?
Okay, it says, what are the most effective ways of protecting family members' mental health or caregivers' mental health?
How to protect them? What is the best way to protect them? I think the best way is psychoeducation, because my experience is you first you don't understand what's going on. You understand that there's something serious going on with your loved one, but you don't understand. You're at loss, and all of a sudden the person is in a hospital. Nobody sees you, so you're at loss, and he does need, or she does need help, but and has needs, but nobody tells you what to do and how to do it. So you're completely at loss. And a person is very often an adult. That means he's over 18. So if you're a parent, you have no right to ask for anything. And you're completely at loss. So this is why it's very important to be either to have, as Roman pointed out, somebody in the healthcare unit who is able to talk to you and say, go there, at least go to an association if nothing has been organized in your hospital, and then try and find the association, then you'll be safe and you'll be welcome and you will not be judged. And I think the way to cope in the long run with the severe mental illness is to build your own network of peers that are just like you. So you don't dare speak about the disease in the open air, because people would not understand it, or they would minimize the situation, or they will make you feel guilty about it. So the only situation is to go and find peers who would listen to you, who will not judge you. And of course, would be fantastic to have a program right at the hospital that would be offered to you to speak about you, because when you are the crisis, and when the situation is a crisis, it is overwhelming, and you're completely speechless. So burden is very high, and you start developing insomnia, anxiety, depression. It depends on each person, but it does happen. So to cope in the long run is to look after yourselves by meeting peers. Because even if you think that these severe mental disease are not spread, it's not true, because everybody remains silent about them. But so many families are affected with it, but they don't dare speak about it to protect their loved ones, because you don't want to mention that you have a loved one who has delirium, or who doesn't do anything but being locked up in his own bedroom. So you just don't want to mention it, not because you're ashamed, but also because you want to protect your loved one, because you know it's a disease. So you need to have these safe zones. And a hospital can give you a psychoeducation, but it will stop. So the safe zone is the association family, because then they can become close friends. Maybe they are not going to be your close friends, but at least they're going to build up the support you need. And then you can cope in the long run because there are high ups and downs. So you will start speaking to somebody when something is going worse, and the people will listen to you.
Thank you, Emmanuel. Very, very full and honest and forthright response. Elizabeth and Roman, do you want to add anything to that question?
Just one word on the importance of taking care of oneself. Because typically the caregivers think that the first most important things to do is to take care of their loved ones, and they forget that they need to take care of themselves. And when they spend time just meeting friends, doing nourishing activities, they think that they feel guilty. And part of our job in hospital services, but also in the programs offered by the association, is to say this is not being selfish. It is not. There's no need to feel guilty. It's absolutely key that you take care of yourself, that you spend time with your friends, that you do whatever you like, whatever is nourishing in the cultural, sportive, or other areas. Because if you want to continue to be performant in your role as a caregiver, you need to refill your own batteries. So this is key for me. I'm a psychologist, and I wouldn't say anything different.
Thank you, Elizabeth. Roman, do you want to make a comment before I move to the next question?
Maybe the last one, it would be to emphasize on the critical importance of earliness and systematicity, because when it comes to caregiver support, it should be systematic. So it's quite challenging to implement systematic things in a healthcare setting. It means that all healthcare professionals should be at least aware of the situation. And then the earliness, because the earlier the better, the more efficient. And it can be challenging too, because often it takes time for caregivers to efficiently consider themselves as caregivers. So sometimes you need to develop proactive outreach approach, so that healthcare professionals they offer support, they speak about family organizations to the relatives of people living with a severe mental disorder, even though those individuals may not consider themselves as caregivers themselves at the moment.
Thank you. But the second question I'm going to give you is not unlike the first question, but it's framed slightly differently. I maybe ask Elizabeth to respond initially. And the question is, what are the means of enhancing family caregiver resilience in mental health? How do we make people stronger? If that's the right word.
I think that we just mentioned different strategy, just with the question, the first question, but I would sum up it and with early intervention, not being alone, being in a network, being in associations, taking care of themselves, of the caregiver, spending time with friends. I think that all these ingredients are the key ones in order to enhance the caregiver recovery, and in a relationship, if in a coordination with it as a respond, because this bi-directional is also a way to better help the loved one who suffer from a mental disorder.
Elizabeth, Roman, do you have anything to comment?
Maybe one last thing, maybe recognizing caregivers as key partners, as real partners for healthcare professionals, because I mean the hospitalizations they are getting shorter and shorter, and so we are really relying a lot on caregivers, on families, and for healthcare professionals, it's not always natural to consider themselves as key partners. So we really need to listen to them and to recognize their very important role, and to decide important things taking into account their opinion, their possibilities, their views. So this is very important, I think.
Thank you, Roman.
If we may,
Emmanuel, sorry, Elizabeth.
oh, sorry. Go ahead, Manuel.
Yes, I would say to enhance the resilience, in Prospect and Model 7, we talk about pairing, the pairing effect. That's because the person is the loved one, the PLE person, the lived experience. You want to save this person, you want to do everything for the person, and you should stop this pairing system. And if stop the pairing means set limits. And it's a way for the person to strengthen the fact that you believe in this person, that she or he has abilities. I will tell you an example because before being a chair for EUFAMI chair, I used to be a prospect facilitator. And I remember the story of a sibling who came to a prospect program. And she used to be called up at night, every single night. It was going for years now by her brother. And she would pick up the phone because the brother would have insomnia, suffers from schizophrenia, would have insomnia. I would call her. And she didn't dare set limits because she felt guilty. She thought, oh, he suffers from a severe mental disease and I'm so healthy. I should pick up the phone. And it was a nightmare for her. It was going from bad to worse. And she decided at the end of the prospect model, I don't know if she managed to do it, but she had at least realized that she was pairing with her brother. So she should stop picking the phone at night when he was calling. And she had to set limits before, not at night, grabbing the phone and getting very nervous. That was not the best solution. But it is so difficult. So I think this pairing effect that we analyze in Prospect is very useful. It's very important to be aware that we all have this tendency of pairing with our loved one because we feel guilty and we want to save and we want to care for him or her.
Thank you. Very, very well said, Emmanuel. Elizabeth, did you want to make a comment before the next question?
Yes, I want to comment on what Romain said about stressing the point that caregivers are partners in care. And there is an important piece there, and I'm so happy that the EPA decided to open this space and time to this topic of caregiver, because one of the key issues, in my perspective, is also to raise awareness about mental health professionals, about the real role that caregivers can play and must play. So we have to offer support to caregivers, but we also, I think that EPA is very well placed together with EUFAMI to also take actions targeted to mental health staff in order to explain what our caregivers needs, what the key role they have to play, and include them in the care pathway. Thank you.
Thank you, Elizabeth. That brings us to the final question. We've 2 minutes left, so I just got a very brief response from Emmanuel, Elizabeth, or Roman to the question of how do we convince senior clinicians, decision makers, public authorities, and so on, healthcare authorities about the importance of family, as we've been discussing. Elizabeth, I'm going to ask you to.
I should repeat just what I said, but I think that Roman has powerful thoughts on that.
Okay, that's fine. Roman?
I think you have to highlight the many advantages and forces of caregivers psychoeducation. First, we have said it, caregiver psychoeducation is one of the most effective interventions that we have in psychiatry. It is recommended by international recommendations. The results are very robust, so it should be implemented. It is our duty to do that. First one. Second one is prevention. we know that in mental health, we do not do prevention enough, and the earlier we take care of caregivers, the better for themselves and indirectly for the persons that they care for. Also, ethically, it's a good practice. I mean, it's a really good practice to take care of caregivers. Another one is economical. I mean, for head of departments, it may be at first considered as an additional expense, but at the short, medium, and long term, the great beneficial effects of caregiver psychoeducation, it is way better than the initial expense. And last one, I would talk about attractivity. I don't know if it is the same for all the countries in Europe, but in France, we are very faced with decreased attractivity when it comes to mental health professionals, medicals or paramedicals when it comes to working in psychiatry. And caregiver support has been seen by those who are practicing caregiver support as a very interesting and very important way and very attractive dimension of their practice. So there are a lot of advantages when it comes to providing caregiver support.
Thank you, Roman. And Emmanuel, a very brief response to what you've heard in that question.
I completely agree with what Roman and Elisabeth has said. I would just ask, as a national association, and in EUFAMI too, we do a lot of advocacy work for ourselves. We are very active. We do. We go to Parliament, European Parliament. We go to ministers. We go to a lot of to tell them help the helpers. Very important fact, and also we are part of the solution. We need to be taken into account.
Thank you. Thank you very much, Emmanuel. Time is against us. Before I hand back to Mariana, I just want to thank each of you personally for your presentations and the work you put into it, and to thank the audience, obviously, for their respectful attention. We've looked at a very important subject. For me, some of the key words that have come out are partnership, very, very important word, the need for support, the need for information of whatever type of information it is, and the need for preventative and early intervention activities to get the best in terms of recovery for people who are our loved ones. The one thing that did come out as well, and I think we all know this, is that people who are family carers don't choose that. It's not like choosing a profession. It happens to you, and it is difficult for those of us who've been there. It is very difficult to face the trauma, the crisis, the lack of knowledge, everything that happens, and then over time to become able to manage and deal with that situation, and as many caregivers do, devote themselves to making sure their loved one gets the best possible opportunity in terms of recovery and returning to a quality of life that's acceptable to everybody. So I think, thank you for all of the wisdom that's shared, and best wishes to everybody who is involved in caregiving. And we will hopefully meet some of you in future at other events and activities. But for now, I just want to hand back to Mariana, who has been silently listening to everything that has been going on for the last hour and a half. Thank you, Mariana.
Thank you so much, John, for sharing this Q&A. And we're now coming to the end of the webinar. So, of course, like 1 hour and a half is not enough to cover this important topic in all angles. But I really want to thank all speakers and everyone who joined today for this important conversation. I guess what we heard today also reminds us that caregivers are not just supporting recovery, they are really an essential part of recovery. And yet, the well-being of caregivers, the resilience, the mental health are very often taken for granted or overlooked. So I think today's session was a very important time for us to take a moment to reflect of what are the interventions that exist, what is the evidence around these interventions, but also reflect a bit more broadly for those of you who are joining us today that are also caregivers, to reflect a bit about your role and the context of your role. As John just mentioned, this is not something that one necessarily chooses. It happens to us. So I think it's important to reflect that. And I guess one of the messages to take forward is that supporting carers, it's not optional. It's really like a core component if we really want to have high quality mental health care. So when carers are supported, when carers are listened to, when carers are empowered, then recovery really becomes more sustainable for everyone involved. And we can't really have high quality mental health care without involving carers at the heart of what we do. So as a take-home message, and my call for everyone here today would be, let us continue to move from recognition to action. Let's do partnerships. Let's continue this partnership between the European Psychiatric Association and EUFAMI. And let's ensure that caregiver support is not just something we value in principle, like theoretically, but something that we consistently deliver in practice. And then finally, if we really want to have a compassionate mental health system, and I think compassion is also important to bring when we're talking about carers, then we really must ensure that compassion extends fully to those who so often give their time, energy, their lives to others. So thank you all for joining. Thank you for all these reflections. And I hope you have a rest of an excellent day. And I hope you continue sharing this message in your clinics, in your services, with your colleagues, with your families, and inside yourselves. Have a nice day.